Welcome to Practical AI in Healthcare, the podcast that cuts through the noise to spotlight real-world solutions delivering real-world value. From patient care to clinical research, from life sciences to patient engagement, we focus on what truly matters in healthcare today. No hype, no theory, just practical insights where AI is making a true impact. Dr. Stephen Lapkoff and Dr. Leanne Rosenblit are your hosts as we explore what's real and moving the needle in this exciting new domain. Welcome aboard and let's get to it. Hello, and welcome to this week's edition of Practical AI in Healthcare. My name is Dr. Stephen Lapkoff, and this week I'm actually on my own because my partner, Dr. Leanne Rosenblit, is on spring break with his kids. He'll be back next week. This week, we have a guest who we met at a conference in Boston a few months ago at the Beth Israel at the TCI Network. We have Danny Van Leeuwen. Danny is a nurse. He has background in giving actual physical care to patients. He runs his own podcast called The Health Hats, and he's been using AI in both his personal life and in his professional life very extensively. Also, Danny has a significant medical condition, and I'll let him explain that in the course of the discussion, because it's with that lens that we got introduced at our patient-centric AI conference, and that's why we thought it'd be a good idea to have Danny come and have a chat with us. So welcome to the podcast, Danny. How are you today?
I'm good. Thank you. Thanks for having me. I appreciate it.
So Danny, as you probably have heard because you've helped us with our podcast, and for that, I want to say thank you. For those who are listening in, Danny runs actually a group that helps folks running podcasts improve their podcasts. And he's had Leanne and I on many times to listen to critiques and feedback, and it's been very, very helpful. Danny, we often start our podcast with asking for folks' origin stories, like how did they get their cape and their superhero tights? What did you do to get you to this point in your life? And just tell us the background of what brought you here.
Oh, thanks. So I'm a child of Holocaust survivors. And my parents, when I was young, were active in the civil rights and fair housing movement in the 60s. And when I was 16 and I was thinking about the war in Vietnam and worried about getting drafted, I wanted to learn what I could learn about the draft and how I could protect myself and manage. And I went to a church in downtown Detroit, and I went for a session of draft counseling as a little precocious at 16. And I found it fascinating, and they found me fascinating, and they encouraged me to become a draft counselor. And so I actually took their course and became a draft counselor. And what I learned is that you change systems from the inside, not the outside. And I learned how the sausage was made. And that really helped me, really pointed me in a direction. The way I got into nursing is really because I didn't want to cut my hair. I had an opportunity for a job at one point, and I could have read water meters or become an aide at the Detroit Psychiatric Institute. And reading water meters paid more, but I didn't want to cut my hair. So I got the job as a nurse's aide. And while I was there, they introduced me to the idea of going to nursing school, which was amazing.
You got paid more to read water meters than you did?
Yes.
That's unbelievable.
Yes.
Life gives you some real interesting turns and twists, doesn't it?
It does. And I was really fortunate because my first jobs in nursing were in physical rehabilitation and home care. I just happened to be in a place where the Holyoke Visiting Nurses was dying to hire a guy. And I was a brand new nurse. And they ended up hiring me. And so my first introduction to nursing was not in acute care. It was in home care. And actually, I was the first male public health nurse in Western Massachusetts in 1976. And really what I learned there was that most healthcare does not occur in the medical system. It occurs outside the medical system. And so when I ended up getting into medical care, it was always so interesting to me that everybody there thought this is where health happened, which it doesn't. Over the 20 years of working as a nurse, I've worked in, other than rehab and home care, I've worked in the emergency department, I've worked in ICU, I worked in pediatrics, behavioral health. And after about, I don't know, 15, 20 years, I shifted from becoming a student of individual health to a student of organizational health. And what I mean by that is I got into performance improvement. I led a couple of electronic health record implementations. I had a couple of gigs in the C-suite. I did some consulting. Now, becoming a patient. So in 2009, I was diagnosed with multiple sclerosis. And when I was diagnosed, I learned that I'd had it for 25 years. Since my father died young, he died at 45 when I was 19 of his second heart attack. And so every time I would have some kind of episode, I would get a cardiac workup. And by the time the cardiac workup was done, the episode was over. And this went on 2, 3, 4 times a year for a long time. There was a pattern there, and nobody was connecting the dots for 25 years. That's very important to me because the pattern of what was going on was in my records for 25 years, but nobody had synthesized it.
Yeah, they may have been biased, right? Because of your family history and having these episodes, as a clinician, you get very biased by family history, and that can actually lead you down roads which may not be correct. And it sounds like that's precisely what happened with you.
So I want to bring in the caregiver role because I have been a caregiver for my grandmother, my mother, and a son in their end of life journeys. So I've been on many sides of very difficult decisions. As you said, that my shtick is health hats. And I'm health hats because I'm a patient, I'm a caregiver, I'm a nurse, I'm an advocate, I'm an informaticist, I'm a podcast host. I wear a lot of hats. And wearing many hats has gotten me a seat at many tables because they can check off boxes. When it was really different to be bringing patients on board, I was an easy choice. I was at the table for technical expert panels at CMS, at National Academy of Medicine, at AHRQ, National Quality Forum, PCORI, Patient-Centered Outcomes Research Institute. But really, I wasn't really there in it for the seat itself. My goal was always to open seats for people who weren't there yet. Now, let's build the bridge. Since this is a podcast about AI, let's build a little bit of that bridge. So my first serious experience with, I don't know about my first. I was involved in something that you probably are familiar with, which was the Blue Button Plus program. And my goal in that, I was there as both as a patient and as somebody who was working with people with disabilities. I was VP of quality for an organization that supported about 40,000 people with disabilities. And my goal for that, couple of years of weekly or every other week, I can't remember, calls, was to add a caregiver field to the data set and to also introduce the idea that what people needed was information that would be able to say what works for me when I'm in pain and what works for me when I'm afraid, which with a lot of the people that was an issue for me, and it was an issue for the organization that I was working with at the time. Now, I have to say that the caregiver field got added, so I felt some success in that. But as a nurse leader in the informatics group I was part of, really, they were only interested in putting a name in the field, not doing anything with that information,
Just
which I
basically just collecting the data. They didn't care what the data was used for, is what you're saying?
correct. Yeah. And I got no traction on the pain and fear, which now that I'm older, I understand why, how difficult that is. Nevertheless, it's something that's important to patients and caregivers. So I think I would close this section with that I am both an early adopter of technology and a rapid skeptic. I'm kind of making this number up, but I probably tried over 100 health apps. And I would say that I've used 5 more than 3 times. And so I think there's a gap between what's promised with digital technology and what's useful for people. So that's really why I'm here and what's guiding for me in this.
So let's take it to the next step. So in our pre-call, I didn't even know about your personal background to that degree. We can take that one offline later. Let's change gears and talk about the challenges that you've seen. You opened the door a little bit on that a few minutes ago.
Yeah.
In terms of people wanting to collect data, but not necessarily doing much with the data, not being able to understand the true value of the data to some degree. And you said it yourself, people weren't connecting the dots.
Yeah.
Medical records have always been complicated. They've always been bulky. They've always been full of information, some of which is really relevant, a lot of which is not so relevant. And connecting the dots to making that an important information source is not always an obvious task. What was the particular angle on that challenge that you were trying to gun at?
Well, I think we have to take a step back and think about what is, I'm just going to speak for myself, okay? I know that I often, as I said, I get asked to sit at the table because people can check boxes like that I'm a patient. I want to be clear that I'm a privileged white old man with MS who wears a lot of hats living in Boston, but I'm an N of 1 and I don't represent other patients. I'm representing myself here and my perspectives. My goal in terms of my health is best health. And what I mean by best health is optimal health and function, physical, mental, spiritual, not a cure, but best health for where I am, what I have right now. And to get there, I need my own health data. So not just what's in my clinician's chart, but what I know about myself. So my circumstances, my environment, my history, my habits, not just my medical history, my life history, my treatment responses. And so that's like patient reported data. And that's stuff that's only exists because I observe it and sometimes I record it. And that's where it falls apart right away. You were just alluding to some of it, that there's all this medical data and what's useful about that. When I think Dave DeBronker was a guest on your show, when he launched his Gimme My Damn Data campaign, I responded to him with, watch what you wish for. You'll be trying to drink dirty water from a fire hose. And that was years ago, and it's still true. So 6 months ago, I've been on a mission to gather my medical data. And I've been with my primary care practice since 2011. And I wanted my data from 2011 to 2025. This was like in December. I started on this crusade of trying to get my data. And actually, 2 months later, I got a 4-pound box of paper. And it was paper that was not in chronological order.
Oh.
And it's just sitting right here. I mean, I've scanned.
Did it print out of Epic or something, or was it actual?
No. Well,
notes.
It's a computer printout. It seems like it's a vendor that they use so it's a combination of,
It wasn't digital. They sent you a box of paper.
yeah, it was a box of paper.
Okay.
And then I use a lot the Beth Israel Leahy Mont Auburn system. And I asked for the last 3 months of my records, and I got 296 pages of redundant, non-searchable PDFs. And I got that in 15 minutes. But still, maybe I had I see a lot of doctors. So maybe I had seen maybe 8 or 9 visits, and it just happened to be a 3-month period that was busy for me. But I got 296 pages. And so that really adds to your comment, which is that access to data and access to usable data are really different.
Oh, absolutely. And and I'll tell you, in my world, so I think you know that I've worked in life sciences for many, many years, and we are consumers of healthcare data on many levels. We consume medical claims, we consume electronic medical records. And one of the hardest things about using medical records for research or for outcome studies and things like that is the very fact you're describing, which is the data tends to be sparse. It tends to be poorly organized. It doesn't always come in an encoded fashion. Thank God most of what we get these days is at least digital. No boxes of paper for us these days, but it wasn't so long ago that when it was all paper, we couldn't get that data in the first place. It just wasn't even gettable. So at least you made some progress. I know that you sit on some national level boards around outcomes, and you could talk about that in a moment. But those boards are trying very hard to come up with outcome studies and ways of, let me back that up. They're coming up with ways of using data to perform outcome studies by harmonizing and distilling down to usable forms of this EHR data, which is so challenging.
I think what's key, I'd like to focus on my data. And so what I want to do is I want to see patterns. I want to see patterns that takes my circumstances, my environment, my habits, my treatment over time. And because I think that these patterns are how I formulate the right questions. So the right questions before I go into a clinical encounter, they're how I track when something is actually working. And it helps me to coordinate across care teams that don't talk to each other and make decisions that I can live with that help me attain this goal of best health. So that's the job. Formulate better questions, seek better answers, make better decisions. And AI is the tool that I try to use to do it. Now, whether it's up to the task or not is different. I want to stick in the nursing angle, if you don't mind,
Please,
for a
absolutely.
second. Okay.
Yeah.
So, one of the things that I learned the way I got started in nursing is that my goal as a nurse was to put myself out of a job. So that sounds counterintuitive. But what I mean is from minute one with a patient and family, I'm planning my exit. And to do that, I need maximum face time. I need real present, real conversation, real relationships, not less charting. I was going to say not charting, not documentation. So that's just ridiculous, but less. The way you do that, I think, is less charting, less documentation, not hunting through information you can't find. And that's where nursing, that's a genuine promise. So pattern recognition across specific cohorts of patients. So as a nurse, even though I worked a lot of different places, in each place I worked, there was commonalities so when I lived in West Virginia and I was an ER nurse in a super rural hospital, if I had had more information about my patients, their families, I could get an AI could help me surface the patterns that exist for the people that I'm taking care of, I think I could get time back as a nurse. And if the nurse gets time back, then the patient and family gets the presence of the clinician. So that's the trade that I'm interested in. The thing, I want to go back to that thing about pain and fear. So, and I want to add what I've learned since whenever that was, working on the Blue Button Plus. I want to add cognition.
Okay.
So when you think about it, that the data almost never captures the variability of pain, fear, and cognition. And those things are really important because pain changes what you can do and what you can decide. Fear closes your heart. It closes your mind. And so when you're scared in a clinical encounter, you're not making good decisions. And cognition is, it varies. Like I can absorb, better at 10 in the morning on a good day compared to 3 o'clock in the afternoon when I'm spent. This is you can extrapolate this to other people. They have their own particular patterns and circumstances. But I think what I'm trying to get at in all of this is it isn't first about the data. It's first about what about life and what about the things that are important to people, patients, caregivers, and the clinicians that they partner with. And how can AI help them?
So you've explained to me in the pre-call that you're doing some of this work. So maybe you can unpack a little bit about what it is you're actually doing with it and how it's helping, or in some cases not helping, those efforts.
Yeah. I mean, I would say that what have I done? I've done different things. One of the things that I've done is to try to build my toolkit. So when I say build my toolkit, I'm a conglomeration of symptoms. I mean, I'm not MS, I'm not my symptoms, but they're big and they're there. And I feel like I'm trying to figure out for anything that I have to deal with, whether it's any of the different kinds of pains I have, my anxiety, my bladder, my mobility. I have challenges and I need a toolbox. I need a toolbox. And the way I think is I need at least 3 things that will work so that when they happen, I got something I can go do. And pretty much the most common thing is drink water. Drink water is by far the most successful intervention across all of my symptoms. It's kind of amazing. It's so cheap, so easy. It isn't the drugs. Okay, but so how do I do that? Well, for me, I've done that partially just in my head. Partially, I've done that by keeping lists. Like I keep track of the steps I take. I keep track of the amount of time I play music. I keep track of my falls. I keep track of my weight. And so I use digital tools to do that when I can. I also record my clinician visits.
When you say record, you mean like audio record or
Yeah.
Okay.
Yeah, audio record. And until recently, I used a bridge.
How did you get to use a bridge? I thought the bridge is only selling basically into doctors' offices from the clinician side. You got access to it?
I was before that. And they started as a patient-facing product. And actually, they sponsored my podcast for 3 years. So I was pre that. So putting all that together, I play with trying to put into Claude. There's nothing magic or special. It's me playing, just trying stuff. Some of it, my wife will say, hey, she sees a pattern. My kids will see a pattern, or I'll...
Give us an example of what this looks like. I mean, you're saying you're giving Claude or another LLM like a series of symptoms, or you're giving it a series of plus your day. Like, unpack it and let us know.
Yeah.
What are you giving the system and how's it working for you?
I've done a couple of different things. One is I have a spreadsheet and I just put the spreadsheet in as a document or whatever you call it, when you have a project. And I load my spreadsheet and I keep an annual summary and I keep the year that I'm working on. I will have fits of journaling. This is not something that I am super consistent on, especially when I'm struggling with something. If I'm struggling with my blood pressure, or I'm struggling with my mood, or I have a progressive mobility thing going on. And I'll put that in and I'll prompt. I'll say, do you see a pattern in this?
Giving you some insights? Like, give me an example of some of the insights it's actually given you that you didn't see yourself.
I've gotten it's kind of humorous, but I've gotten you thought about seeing a physical therapist. And I have a physical therapist that I don't go to very often. My relationship with her is I go for a tune-up. I've gone to her for 16 years and maybe I've seen her 12 times. I'm not walking as far. I fell on a few times and I'll get this suggestion, once I had a medication that I was taking for neuropathy and my mood had changed considerably. And I got a thing on, that might be a side effect, talk to your doc, have you talked to your doctor?
You got that out of the LLM? You fed it
I did.
The LLM? And it suggested it was a side effect, which you didn't figure out.
I didn't. It turned out that my neurologist said that he said, sounds like you have an allergy to it. And he wanted it to be listed as an allergy because he said it was very possible that he's had people that have had a problem, but whatever.
When you tell me that you've loaded your data, you give the LLM your signs, your symptoms, you give it your labs, you give it what's in the system, and it comes up with a recommendation that you hadn't thought. Now, you're a clinician. You're a nurse. You've been a nurse for many, many decades.
50 years.
50 years. And does it surprise you that it comes up with stuff that you didn't see?
No.
No?
No. I mean, to me, no.
To be honest with you, if I did what you just said and it came up with something completely radical that I never thought of and it was right, I would be scratching my head and thinking, okay, that's beyond interesting. I better pay more attention to this and maybe I want to use it differently because it's not just you using it, people around everywhere are starting to use it for the same exact way. That has implications in the medical system, right?
It does. I mean, I think when I tell my neurologist, he laughs and he's like a whatever works kind of guy, he feels like he doesn't have all the answers and that he likes those stories. I feel like I've learned, I think Amy Price, right?
Yeah, very well.
Yeah, we're buddies. And so one of the things that I've learned from her is how to query and how to be skeptical and how to ask questions from different angles, from different perspectives so that so I think that's where the unexpected comes up.
Well, you're describing something that we did at the conference. I don't know if you were in the room in the working group that we did this on, but you're describing, and actually we're submitting a paper on it very shortly on AI literacy. And you didn't label it as such, but you're describing, yourself as being AI literate and understanding how to use the tools. Most importantly, how to be skeptical of the answers, how to interpret the information that's being presented to you. And those are all components of literacy, of AI literacy specifically. And it's, one of the things I'm finding in my world is that painfully few people are indeed AI literate. Even the folks in IT departments in large life science companies or hospitals who even work in the space and think that they're good at it and are literate, sometimes are not. And that has other implications, which are, if people are taking on these really impressively powerful tools and they don't quite know how to use them as well as they should, and if they query them incorrectly, to your point earlier about making good queries, the responses that come out may or may not be to point. And if patients use that information inappropriately because they didn't know how to ask the right questions to start with, that could have deep implications to the healthcare system.
Well, you could say that same thing about doctors.
I will say it about doctors.
I mean, no,
absolutely will.
not about AI, about the advice that doctors give. There's a tremendous variation, and it is very different when I am feeling good enough to be organized and to be directive in the conversation with a clinician. I get a very different output than when I'm not. And I still have to be skeptical of what doctors tell me until I build some trust. And then then there's just too many decisions to make. When you're a person with chronic illness, there's, it's like putting in a kitchen. There's so many decisions to make. And I'm happy for the doctors that I trust to make the decisions for me. But there are certain decisions I don't want to give to the doctor or to AI, like I don't want to mess with my pathological optimism. I want to progress as slowly as possible, and I want to keep playing my horn. These are really important things to me, and I don't give those decisions that affect that. I don't give up.
Okay.
But all the rest of it, I do. And I've worked really hard to build the team that I have that appreciates me and my strangeness and my assertiveness. And, they're not threatened by it. But when
is your team AI literate? Do they also use these same tools in your care?
I don't know. I mean, AI literate is huge. That's just such a big thing. Do they use AI? Yes. Do I know how they use AI? Well, they use what's attached to Epic. I know that. Look, my neurologist, who I just love, he thinks he uses the portal well, because he just keeps adding things to the end of the note. So he feels well, I don't find his notes at all useful. And I tell him that. I tell him what I really want to know is, how am I doing? Am I getting better? Am I getting worse? Am I stable? What should I be paying attention to in the next 6 months till I see you again? And I can't find that in his note. Now, on the other hand, I've taken his note and asked, Claude, which is the agent or whatever you call it I use, and say, here's the note. How am I doing? Have I progressed? How is he measuring it? Oh, well, then I find he's using this scale, right? And it'll come up with, looking through this note, which is 10 years of a note that's 10 years running. And it'll find, I can't remember the name of it, but there's a scale that he uses. And then we'll go back and I'll say to him, oh, you're using this scale. And he goes, yeah. And I said, well, why don't you put that at the top of your note, so that I can find it, so we have that kind of conversation that AI has helped.
Well, that's actually an interesting perspective, that AI is helping to reorganize things. Is one of the use cases that has been discussed at length, actually, and it was discussed at our conference, is using AI to digest medical records. And when I say digest, it's not about ingesting them, which is slightly different, but digesting, which means find all the different pieces, put them together, come up with a narrative that summarizes perhaps 300 pages of information, which may be sparse and may be poorly organized, and bring it all together. And that's actually a task that AI is actually turning out to be pretty darn good at. And that, again, changes the nature of the healthcare system and the healthcare journey.
And it does a fair job. You say it's really good at it.
It's better than I could do. It's better than I could do.
Yes. First of all, that's not your training, and you don't have the time for it. And you still have to review it.
Yeah, of course.
Because I have never used AI that gave me oh, this is great. I mean, the first time I read it, pretty much every time, I think it's amazing. And then my rule is sleep on it and check it again. And then it's oh my God, this, first of all, it just said nothing very fancy, or it got some very basic things wrong. And then I'll say, oh, you missed this and you missed that. And it'll go, oh, you're right, I did.
It also speaks to the concept of keeping a human in the loop, which is
Yes,
something that you espouse and many folks in the healthcare AI
I
world
do.
espouse. Adam Rodman, I think, he was at our conference, he spoke.
Yeah.
He's done a study which shows actually having a human in the loop in some cases actually makes the conclusions worse, believe it or not, which is a non-intuitive finding. And you would think that the two together would be better than either one alone. But so that's now relatively, well, it's not even that new anymore. That information came out about a year ago. So we got to start wrapping up in a few minutes here. So, we didn't cover the concept around outcomes around your 3 T's and 2 C's. Maybe we can cover that in the last bit here, and then we can get to closing.
Okay. So I feel like, one of the questions that you've asked is how has AI helped? Right. And I feel like what I need to tell you is the framework that I've developed over the years, which I've actually shared with, in my AI Claude project that's Danny's Health, what I call the 3 T's and the 2 C's. And this is like the framework I use to evaluate any digital health technology. And so they are time, trust, talk, control, and connection. And what I mean by that is time is, you need time to learn, to plan, to talk, to build trust. So I say the clock isn't the enemy, it's the wrong things filling the time. So the time. The second is trust. Trust can take a really long time. It can happen really quickly. Sometimes you never have it. And in your gut when you don't have it. And most digital health tools, AI, have a trust deficit, I think, not because they're untrustworthy, which maybe they are, but it's really because the people who use the tools, don't trust them. I think it's really important. You can't shortcut trust in the use of any tool. I think talk is really important. It's woven through all of it. Real conversation. There is nothing like actual conversation that is making decisions together, which is a lot of what healthcare is about, is making decisions. And AI can help you prepare for it, and it can help process it. And then control. I trust more when I have power in a situation. So if I'm feeling like an ant ready to be crushed, I'm not making good decisions. Finally, I would say connection it's the human lifeline. When somebody greets you when you cross a threshold, that's a connection. When someone's been where you're going and they can say, oh, that helped me, AI can extend that connection. They can help people find communities. They're available at 3 a.m, but you can't manufacture it. I think that connection is really important. So that's where time, talk, trust, control, and connection. I use that framework when I'm evaluating.
Okay. And that framework gives you a better, how do I say this right? It gives you a rubric, if you will, to go through the information that's coming out of it. Danny, we're going to have to wrap up here in a second. Are there any last comments you want to make that will, help other patients in the space in terms of how they might want to think about adopting an AI tool in their world?
I think that I would say use it, use AI, keep using it, experiment with it. Just like anything else, it takes time to learn. It takes time to be comfortable with it. Use it. I would say advocate for humans in the loop. I don't care what the study says. It's about humans. We are human. Keep it humans in the loop. I would say find a buddy. Do this with somebody else. It's a buddy and experiment. I would say, talk to your clinician about it. It's a good barometer of a physician. If they don't want to talk or blow you off, that tells you something.
It does. Absolutely right.
And I would say, if you're comfortable with it, mentor.
That's a good idea.
Be the buddy. And for clinicians and for systems and developers, I would say you need to have patients, caregivers, and practicing partner clinicians in the design. They need to be there from the beginning. So it solves the problems people have, not the problems that the developers think are there or the venture capitalists thinks are going to make money. And if you have an opportunity, join, participate.
All good.
Yeah, there you go.
All good advice. Well, Danny, I want to thank you very much for your participation in today's discussion. Hopefully that there are other patients out there who listen to the podcast. They'll take something away. For the clinicians out there who are listening, you've heard it straight out from a patient who happens to be a healthcare provider himself. He's got very strong perspectives on how this can be used in a positive and productive way. And I think the framework that he's put together is very useful. Danny, I want to just say thank you for, first of all the help that you've provided helping this podcast get off the ground. It's been really incredibly generous of you and your friends who've helped us a lot. And a lot of the things that have happened on our podcast for improvement's sake have come directly from those conversations. So thank you for that. I want to thank you for being a guest and sharing your journey and sharing your experiences here. For the rest of us, thank you for joining us, and we will see you again next time on another episode of Practical AI in Healthcare. Thank you for listening. Thank you for joining us this week on Practical AI in Healthcare. If you're ready to go beyond buzzwords and hype and explore how AI is truly transforming healthcare, stay tuned for more conversations that get us to what works. Until next time, stay practical.